Good morning, my name's Enid and I'm from the Department of Nuclear Medicine at St Vincent's Hospital, Sydney. I'd like to present to you today a potential solution for when delays occur in hospital procedural scheduling due to time restrictions associated with radioactive patients. Delays in hospital procedural scheduling can not only be costly for the hospital, but can lead to suboptimal care for the patients. The results from our study may be used to modify future healthcare service practices, which may benefit both patients and healthcare system. Following a radiopharmaceutical injection, a patient becomes a source of radiation exposure to the hospital staff who are providing care to the patient. So, example of staff external to the nuclear medicine department that may work in close proximity to the patients are nurses providing bedside care in a ward, a sonographer, or a doctor performing an intervention or procedure on a radioactive patient. But most of the time, by the time the patients are discharged from the nuclear medicine department, their radiation levels emitted are quite low, and there are no distance or time restrictions in place. Our current radiation safety advice guide uses a dose rate of 5 microsieverts per hour at a distance of 0.3 meters to refer to a non-radioactive patient. If the patient's radiation exposure rate are above this level, a radiation caution alert is placed in the patient's notes, which will specify a time period where extended periods of close contact should be avoided. So, for example, at Royal North Shore, a table similar to this is used for a quick reference guide to provide radiation precaution restriction time periods associated with various scans. So, for example, if the patient is having a technetium bone scan, the time constraints for keeping distance from the patient is about 14 hours. This table has been around for a long time, and the data in this table has been generated from biokinetic distribution data found in ICRP publications, and using a theoretical line source model to estimate external dose rate after injection. So if a radioactive patient is required to have an intervention or a procedure done on them in the time restriction period, the radiation safety officer will be contacted for further advice. And healthcare workers would often call to ask if a particular patient was safe enough to have a procedure done. And when we would explain to them that they could indeed proceed with what they needed to do, just as long as they kept within a certain time restriction, we found that that sometimes was a hard sell, especially if the staff had access to this table, which was providing them with information about how long the patient was going to be radioactive for. So this could sometimes result in delays in scheduling procedures. So we realised that we had to find a better way to communicate radiation precaution information. So I'm curious to find out how other centres deal with this issue, as we have no standardised advice on this at a state or national level. So when a radioactive patient is transferred to another location in the hospital, an alert notice is placed in their notes. This example notice is for a patient who had been injected with a gallium-67 radiopharmaceutical. According to the quick reference table that I had shown earlier, the time restriction associated with the gallium-67 injection is 72 hours. So if the patient was injected at 9 a.m. today, then according to the table, this patient will be radioactive for a duration of 3 days, so there'll be time restrictions in place until the 18th of May at 9 a.m. So once the ward staff sees this alert in the patient's notes, they will withhold any further investigations on this patient until after the radioactive period has passed. So we found that the gallium-67 cases were probably the most problematic of all, causing delays in hospital scheduling systems as the operators would wait for this time period to pass before they would schedule any other procedures. So we decided to conduct a small study to obtain real-world evidence upon which we would base our recommendations, whilst at the same time also revisit the way that we are providing advice. We also thought that some of the data in the table appeared to be a little bit too conservative. The method we use is as follows. Exposure rate measurements were collected from nuclear medicine diagnostic patients over a period of 3 months in 2020 using a surveymeter with a H10 gamma energy filter attached. We focused on 6 main scans, the technetium bone scan, the gallium citrate scan, the technetium DTPA renal scan, and technetium lung VQ scan, as well as the technetium gated heart pulse scan and the technetium MIBI scans. So dose rate measurements were made at the interior and lateral midline of the patient at 2 time points, so within 5 minutes after administration of the radiopharmaceutical and at the time of discharge from the nuclear medicine department. Patient exposure rate data were compared to calculation from a shielded line source model using a shielding factor of 0.6. And close contact time restrictions at 0.3 meters and 1 meter were calculated on a dose constraints per radioactive patient interaction of 1/5 of the allowed annual dose limit, so 200 microsieverts, to cover for multiple radioactive patient interactions per year for non-radiation workers. The measured exposure dose rate correlated well with the theoretical calculations. These graphs are results from collected data. Dose rate results taken at 0.3 meters can be useful for clinical staff needing to work in close proximity to the patient, such as ultrasonographers. Patients who received radiopharmaceutical injections for the MIBI scan and a gated heart pulse scan have the highest exposure dose rate, and both these scans do have high injected activities. The scans have different lengths of stay associated with them, so patients who have a lung scan and a gated heart pulse scan are usually discharged within an hour of having their injections. And this is probably why you don't see much of a difference between the instantaneous dose rate and the discharge dose rate. Whereas patients that have received a bone, renal, or MIBI scans, they're usually discharged 4 hours or so post-injection. By the time they are discharged, their dose rate has dropped to below 25 microsieverts per hour at 1 meter. These radiopharmaceuticals clear relatively quickly from the patients. Patients who have received a gallium injection, the blue curve, do not necessarily have higher dose rates than the scans I showed in the previous slide. However, the gallium-67 radiopharmaceutical does have a slower clearance from the body. The patients remain in the hospital for 3 days and have their imaging done on the 3rd day. The purple curve are patients that have received both the bone scan injection as well as a gallium-67 injection, and this often occurs. And the red line here is showing the 5 microsieverts per hour dose rate line, and when this occurs at 0.3 meters, this is when we would classify the patient as being no longer radioactive. So for gallium injections, this is requiring 3 days to reach that point. Looking at the scans that have same-day discharge, here I'm showing 3 example graphs. Again, the red line here refers to the dose rate at 5 microsieverts per hour. When we compare the results obtained from the study to our current radiation safety advice, there appears to be some room for improvement. We find that it takes on average 12 hours for the dose rate to drop to 5 microsieverts per hour for a patient who has received a bone scan, and our current advice says 14 hours. And with regards to the renal scan dose rates, the study findings agrees with the current advice we are providing. Whereas for the MIBI scan, our study suggests increasing the time restriction slightly. The lung VQ scan and the gated heart pulse scan have shown quicker clearance in the study data compared to the current advice. And as shown earlier, the gallium-67 scan results were agreeable to the current advice. So using these findings, we developed new radiation safety guides for the staff working external to the nuclear medicine department. The new look radiation safety guides are color-coded. Scans with the highest radiation precaution associated with them are listed in the red table. These new guides are different to the current as we are moving away from the less helpful advice such as the patient is radioactive until 3 p.m. on Thursday to on day 1 you are able to spend up to X hours within 30 centimeters of the patient and not exceed any exposure limits. So let's look at the red table. The scans that have the highest administered activities or the slower clearance, so on day 0, the time restrictions for close contact care at 0.3 metres is 2 hours, whereas it is 10 hours for 1 metre. On day 1, the time restriction is 6 hours for work conducted at 0.3 metres from the patient, and for working at a distance at 1 metre and beyond there are no time restrictions. And on day 2, the time restrictions is 10 hours for working at 0.3 metres from the patient, and for distances at 1 metre and beyond, there are no time restrictions. The blue and green tables list the scans which have relatively quick clearance and low exposure dose rates associated with them. We have yet to collect data on these scans. These new tables are currently under review. So here is another option where we have a 3-in-1 table. Again, for all the scans, we have time restrictions set for the day of administration, the day after that, and so on. It lists the per annum restriction. The legend for the colour coding in the table is found on the bottom of the table, where a red block on the table refers to only spend a short time in this category, and this case is only for when you need to work with a patient who just had a PET radiopharmaceutical administration. The orange block means that you can spend up to 15 hours per annum in this category. The yellow block means that you can spend up to 100 hours per annum in this category, and the green blocks have no time restrictions on them. We believe conveying radiation safety advice in this way may be easier to understand and follow, and this may minimise procedures scheduling delays, as now the staff are provided with the time limit for how long they can work with a radioactive patient. So in summary, communicating radiation safety information to healthcare workers external to the Department of Nuclear Medicine can be challenging, and sometimes this can cause unnecessary delays in procedure scheduling. There is currently no standardised radiation exposure advice for non-radiation workers that have to interact with radioactive patients. We conducted a small study which we would like to expand to include data from other centres, and we changed the way that we communicated our radiation safety advice from providing information about how long a patient will be radioactive to how long the healthcare worker can work in close proximity to the patient. I'd like to thank the staff from the Nuclear Medicine Department at Royal North Shore Hospital, in particular the Nuclear Medicine Technologists, the Chief Technologist Liz Bailey, and the Head of Department Paul Roach. I'd also like to thank Nick Forward, who is at Concord Hospital, for his help explaining the origin of the data in the current radiation safety advice table.